reproductive medicine and minimally invasive surgery with more than 20 years of experience. She has practiced in UK and Canada for a period of 12 years. Her work related to reproductive medicine has been published in various national and international journals. Most advanced ART treatment has been started in Oasis under her leadership. Dr. Durga has also conducted several conference workshops worldwide. And Madam, I would like to invite you to start the second presentation on pre-genetic implantation screening and its Indian context clinical applications.
Good evening, Dr. Jatin and good evening, Mr. Subrata Ray. Can you see my screen?
No, we can't see.
Okay, just
we can see you, but not the deck.
All right.
So, in case any challenge, you let me know because I have your deck as a backup.
It's showing me some error, sir. Screen sharing has failed to stop the error code.
There's an error code which is coming up.
Okay. So the idea, would you check it or shall I share mine?
ट्राय केले प्रेग्नन्सी खातीर कितें जाल्यार एक म्हणटा तो तुजो खर्च वाडटलो कितें दुसरें म्हणटा ते प्रेग्नन्सी जावपाचे चान्सीस कमी जाता सेम जर आमी आमचे कडेन जी अंडी जी स्टोर्ड आसा ती तर वापरली कितें जाल्यार तातूंत प्रेग्नन्सी जावपाचे चान्सीसूय वाडटा आनी तुजो खर्चय कमी जाता समजलें सो हें तुवें डिसायड करूंक जाय की वॉट इज इम्पॉर्टंट.
Yeah, if you do not mind, then I can share your deck which I have you had sent me.
Right, so there are just a few additional slides that I had added on to that. So what I'll do is I'll just send it across to you right now.
Okay.
Reports no
problem. It will take some time.
We'll just send it to you right away.
Okay. जाल्यार आमकां ताका डोज इंजेक्शनाचे खूब दिवचे पडटा which will be bad for her health कितें आनी at the same time अंडी मेळत न मेळत हें प्रश्न. सो बेजिकली कितें करतात असले कंडिशनाक आमचे कडेन जी अंडी ऑलरेडी स्टोर्ड जाल्ली आसा कितें ती आमी वापरतात आनी तुजे स्पर्म्स वापरतात तुजी एज वाडिल्ली आसा कितें सो तुजे स्पर्म्स कितले बरे आसा तें आमकां पळोवंक जाय कितें सो जर तर स्पर्म्स अशें तुका सांगलां हांवें स्पर्म्सूय बरे आसचे पडटा एग्जूय बरी आसची पडटा आनी पिशवी बरी आसची पडटा. आतां ताच्या पिशवेक तर कांय प्रॉब्लेम ना कित्याक आतां सद्या कडेन कितें आसा ताका मातसो शुगरीचो प्रॉब्लेम आसा कितें सो ते शुगरी खातीर रगत गोड जाल्ल्या कारणान केन्ना केन्ना रगत पिशवेक जें वता तें केन्ना केन्ना कमी वता सो तें कमी जाल्ल्या कारणान तातूंत प्रेग्नन्सी धरूंकूय केन्ना केन्ना प्रॉब्लेम जावंक शकता. सो ते बी सगळें आमकां पयलीं सगळें चॅक करून पळोवचें पडटा भितर पिशवेन जंय भुरगें घालता तातूंत भितर कितें इन्फेक्शन आसा कित्याक डायबिटीज लोकांक इन्फेक्शन जावपाचे चान्सीस चड आसता सो इन्फेक्शन आसा काय ना कितें भितर कितें पड्डो आसा काय ना तो भितर कितें म्हणजे कितें पॉलिप आसा म्हणजे गाठी जाल्या कितें जालें तें सगळें.
So Mr. Ray, we have just sent you the presentation.
तर नॉर्मल जालें.
Okay, it's till now it has not reached. It's a large file, I guess.
Possibly. There aren't any videos in this, but
Okay. But it takes some time.
उदक तर सारकें पडना जर कितली बी तुवें बरी घाली तातूंतल्यान रोग येवचो ना. सो त्या खातीर पयलीं जमीन आमकां पळोवची पडटा कितें ही जमीन कितली बरी आसा ती पळोवन आमकां पयलीं पिशवी कशी आसा.
While it comes, maybe what I was thinking that Dr. Jatin Shah, if you don't mind, I can put one or two questions which are already coming.
Okay.
Yeah, sure. That's a good idea, I think.
Because it is coming.
Yeah,
Till now it has not come.
सगळें तर सारकें आसा कितें
Hope, Dr. Madam, you have no challenge, no?
no.
It has not come. Yeah. Okay.
आता जर
Okay.
सोनोग्राफीचेर कितें
Okay.
कमी
Yes.
जावपाचें
So there are a couple of questions on your presentation, and one question is: are there any chance of growth of endometrium
समजलें
with our stimulation?
No, I showed that evidence. There are a lot of studies now, about 6 or 7 studies which clearly show that there is no risk of recurrence, even with aggressive ovarian stimulation, with repeated IVF cycles. So that doesn't happen, for sure.
Okay. Yeah. Okay. Good. Thank you. There is one more which is frozen embryo transfer protocol in endometriosis patient. Your advice, please. I think you have already told that you can go for.
So since we have time, basically in the frozen transfer, we like to give them a depot. Because in endometriosis, we want to suppress all those Hoxha genes and pinopods and all those things which are abnormal. Hello. So therefore, we give them an agonist depot on day 21. Then you wait for menstruation. Then from day 4, we begin estradiol valerate, usually 2 milligrams TID or QID, so 6 to 8 milligrams a day. We call her in on day 14 to assess the endometrium. You can also add your sildenafil and aspirins and whatever else you believe in. On day 14, if the endometrium is adequate, you can start progesterone. If it's not, then you wait, you increase the dose to say 12 milligrams total estradiol per day. Wait for 1 more week. Now, since you've given the agonist downregulation, she will not produce a follicle and she is totally downregulated, suppressed. So you have a lot of time to work on a poor endometrium. You can then on day 21 even do your intrauterine PRP or GCSF, again wait for 3 or 4 days and then start progesterone from day 25 and do a transfer by day 30-31. So that is the usual protocol that you follow for a FET cycle in endometriosis.
Okay, thanks. Just checking my mail. No, it has not yet come. So I can take one more question. This one is during ovarian pickup, if endometrium comes in between your egg retrieval, what next?
Yeah, so that's what I mentioned in the talk.
Yes.
You don't have to try and go around because it's not possible. You can easily puncture the endometrioma and go to the follicle. Just release, don't press the foot pedal. So when you are entering the endometrioma, make sure you have removed the foot pedal, the negative pressure suction unit, so that you don't aspirate too much. A little bit will come in, but you don't aspirate too much chocolate fluid. Then enter the follicle and then activate the pedal. So that way you can avoid too much of contamination with endometriotic fluid. And then as soon as it is, try to change test tubes immediately. So you will see in the tubing in which the oocyte is coming, you will see the brown chocolate fluid. And then suddenly there will be a gap where it will become clear. So at that point, the nurse should change the test tubes so that you avoid contamination of that follicular fluid. Then of course, little bit micro drops will always go, which the embryologist will easily wash the oocyte and take it out and clean it up. So that was a bit overhyped in the beginning that, if there is contamination, the egg is ruined and the embryo is ruined. Doesn't really matter, doesn't really happen. And usually the outcome is the same as I showed.
Is it visible?
Hello?
Yes, Dr. Subrat. Yes, Subrat.
Yes, visible. Thank you.
Yeah. So while you are presenting, you have to tell me if I have to move and all. Yeah.
Absolutely. Sure.
Thank you. Yeah.
So thank you very much. And after that scintillating talk by Dr. Jatin Shah, I've been asked to speak to you about PGT. And as OSS, we have been doing PGTA for the last possibly 5-6 years. So we have accumulated quite a bit of data, and I would like to show you what our experience has been. Now, next slide. This is a bit of a disclaimer from MSD. And let me start with my next slide, which actually tells us what the goal of ART is. See, whenever we as a fertility specialists are providing treatments to our patients, what we would like to see and what also they would like to experience is this: having a positive pregnancy test in the quickest time possible and with spending as little as possible. And as fertility specialists, what do we want? We want them to go ahead with a treatment which has no complications, which does not give us multiple pregnancies, and ensure that the baby is healthy and has no birth defects. So all in all, a happy mother with a single live born child with no defects. So this is the goal of ART. Now, when we are really looking at what has been coming across for the last 40 odd years, because today we are celebrating the World IVF Day. Going to the next slide. One of the things that always confounds us is, with the technology that we have right now, with the incubators, with the skill of our embryologist, with the attention that we give to our air quality and everything, what we would expect is that whenever we get a good quality blast, we should at least get an extremely good pregnancy rate. But that's not what we see. Even when we transfer a grade 1 embryo or a blastocyst, we still fail. Why is it? It is because obviously the morphological criteria does not always mean that the genetic competence of the embryo. Now this actually tells you these are the two different embryos, which obviously we are going to be grading them to be good quality embryos. But if you look at embryo A, that gives you a very good genetic competent embryo with normal karyotype. And when we start looking at B, which also is a very good embryo, which is basically hatching, you notice that the karyotyping of this particular embryo is not good. So beautiful looking embryos, which we are going to give good quality, but obviously not going to result in pregnancy. Next slide. So that is where the concept of understanding the genetical competence of the embryo to improve implantation actually came across. So what we are actually doing with genetic screening of embryo is we actually genetically and chromosomally profile the embryo before we put it up for implantation or embryo transfer. And with the genetic assessment, what we are able to actually see is that the 24 chromosomes can be analyzed. And that actually tells us not just like how it used to be with the fish earlier on, where we could only see about 5. Now we are able to see the genetic competence and the whole profile of the 23 chromosomes. And when we are doing that, we are able to select the genetically competent and normal embryo and go for transfer. Next slide. So initially, we used to be calling this PGS and PGD. Now, this terminology has been changed in the last 3 years, and accordingly, we are following the new terminology wherein we call it PGTA when we are checking embryos for aneuploidy. We call it PGTM when we are really looking for, single gene disorders like cystic fibrosis or Huntington disease and so on and so forth. Initially, this was called as PGD, and now we are calling it PGTM. The other two additional, nomenclatures that we are using nowadays is the PGT-SR, which is structural rearrangements that we tend to look for any translocations or inversions and deletions. And PGT-HLA, wherein we are looking for a HLA match for any kind of an effective child. Next slide. Now, when we were also looking at how the advent of PGT went on, we previously used to do a laser hatching on a day 3 embryo and try and remove one blastomere and send it for analysis. Over the years, we have understood that that is going to reduce our implantation rates, and we wait till it becomes a blastocyst, do a bit of hatching, see the outpouching of the trophectoderm cells, and aspirate a few cells from the trophectoderm without disturbing the inner cell mass. And the few cells that are being aspirated are sent for analysis in terms of the genetical competence. Next slide. Now, over the years, again, we have had different platforms, and I think slowly we are reaching some kind of a stability to understand which platform actually gives us the best result when it comes to the different kinds of PGT assessments that we do. Currently, what we are actually looking at is NGS, which is what is giving us the best success rates for an assessment and the best analysis when it comes to aneuploidy screening. And when you're really looking at PGTM, for the monogenic disorders, we are using the quantitative PCR. Now, there was also a committee opinion on this, which said that if we are looking for aneuploidy, then the platform that needs to be used is next generation sequencing, which is NGS. And should we go for PGTM, it is qPCR. Now, there's a lot of benefit for NGS, as this table is actually showing you, is that the turnaround time for us to get the results is much shorter. And the most important thing is it actually gives us a bit more definition about mosaicism. So it gives us more detail about a mosaic embryo and how much mosaicism is there in the embryo. Now, some of them, you might also have some people telling you contradictory that, when we are getting information about mosaicism, it actually is not very accurate, but because sometimes since we are only analyzing some of the cells of the trophectoderm, just because you get a, mosaic embryo, that doesn't mean that the inner cell mass is also a mosaic consisting of mosaic cells. Or the part that you have biopsied from, which is actually mosaic, does that mean that the whole embryo is mosaic? And the answer is no. So even though it does tell us, the NGS platform does tell us about mosaicism, it still brings about more questions than answers, and we are still trying to find our way around it. Next slide. So what are the indications? When would we suggest a PGT screening for a couple, and what are the different indications? Well, initially we started off with these 5 indications, but I'm not very sure we are actually doing justice, or actually these are the real indications for PGT. But initially what we thought was it would help us in selecting embryos for a woman who has crossed 37, 38, because as we know, as a woman grows older, the rate of aneuploidy increases. The other indications are obviously of repeated implantation failure and the recurrent early miscarriages, sometimes even severe male infertility. And also when somebody has been suggested donor oocyte for various reasons like implantation failure or miscarriages, and they don't want to go ahead using donor gametes, we can still offer them PGTA if they are suitable. Next slide. So let us look at each of these, indications, and I'll tell you what the experience of OSS has been. Now, looking at advanced maternal age, next slide. Now, this is what has been our, not just our experience, but this is the understanding that we have, that as a woman grows older, what are the chances of having a genetically normal embryo or a euploid embryo? As you can see, an egg donor who's going to be less than 35 and who has no history of infertility has a chance of 60% of her embryos being euploid. But a woman who's infertile and still less than 35, the chances of her having euploid embryos comes down to almost 50%. And between 35 and 37, it's around 43, 44%. And once you cross 37, but less than 40, it comes down to only having 1/3 of the embryos being euploid. So this is where the difficulty and the uphill, journey begins. And once you cross 40, it comes down to almost between 15 to 20%. And once you cross 42, it is around 10%. Next slide. Now, having that information in the background, let us see how it helps us in terms of a management of a woman. Now, we had a lady who came from Canada, having seen our profile on the net. And she had, or by the time she came to us, she's already 40, secondary infertility. She had previous 3 IVFs in Canada. And of the various transfers that she had with the frozen embryo transfers, in total, she had 6 biochemical pregnancies. And, when all the investigations were done, everything was fine, including semen analysis, DNA fragmentation index, the couple karyotyping. But the only thing was her day 2 investigation showed an FSH obviously at 40 being close to 13 and an AMH of only 1.5. On examination and on ultrasound, she had a AFC of approximately 6. And she was still very keen, and that's the reason why she took such a long journey and came to us and wanted to still go ahead with her own oocytes. So we went ahead and advised PGS for her, and we also told her that because of her investigations, that she might need a dual stimulation. Next slide. From 2 stimulation in the same menstrual cycle, we got a total of 5 blastocysts. And of these 5 blastocysts, we sent them across for analysis. Next slide. And of the 5 embryos that blastocysts that we had developed for her, 2 came back to be normal. A transfer was done, and she actually, it's not just ongoing now, she recently delivered as well. So this is a woman who at 40, having had 6 biochemical pregnancies and having had in every other investigation except her ovarian reserve being normal, still could not achieve ongoing pregnancy, which PGT helped. Next slide. So this also was another lady, and this is a completely different story here. Now this is a 41-year-old who has had 4 IVF cycles, both in India and in Dubai. She never conceived, had no implantations ever, but still very keen to try her own, oocytes, with an ovarian reserve which was good for her age of approximately 12 to 14 in total, and not even a raised FSH or low AMH. But her husband had azoospermia. So having discussed the various options, we decided to go ahead with a PGT for her, and we did ICSI with Tisa sperms, and we developed 3 blastocysts for her in 2 different cycles. And having sent them all for analysis, these were the results. None of them actually ended up being normal. Now, this being the 5th cycle of her IVF, and having understood the reason why she never actually had any implantations, she at that point in time understood that she needed to go for donor oocytes. So in some way or the other, as you can see, one story was entirely different where PGT helped her and in fact helped her conceive. In this story, PGT basically told her the reasons why she needed to move on towards a different option to get herself pregnant. Next slide. So what does literature tell us about the different aspects of PGT in people with raised maternal age? Well, what they have said is that selective transfer of euploid embryos showed that implantation and pregnancy rates were not significantly different between women who are young or older. So what we are trying to say here is, if you have a euploid embryo, it doesn't matter whether you're 30 or whether you're 40, your chances of pregnancy remain the same. Next slide. And this is what even, there was a kind of meta-analysis as well as a review articles which are telling us that when you're doing genetic screening for women, and if a woman crosses 37 years, the chances of an intrauterine pregnancy was 62 versus 37, as was the live birth rate of 57 in somebody who had PGT versus almost 20% if they did not go in for PGT. Next slide. Now, those were the earlier studies in which the platforms that they had used were different. When they looked at CGH and the results of PGT in women who had advanced maternal age, the observations were similar in that when a younger woman compared to an older woman, we put a euploid embryo, there was a similarity in the live birth rates. But what is important is, by doing PGT, obviously the number of attempts that you're going to be given a woman who's crossed 37 was much lesser, and her chance of having a miscarriage was also lower. So these were the benefits of actually, propagating PGT for a woman who's crossed 37. Next slide. Now let's look at other indications as well. Now here we had a 38-year-old woman who came to us, primary infertility, had 3 cycles of IUI. She had 3 cycles of IVF failure as well. And because she's had 3 cycles elsewhere, they said that you can either go for another stimulation or go for a donor gamete. She came to us just for an opinion, and we spoke to her about PGT. Before doing PGT, when we actually assessed both of them, they both had normal karyotypes. So in their cycles, we actually had 5 blastocysts, of which 2 were normal. And then when we did FET with the genetically normal embryo, she had a live birth. And this too, again, with her own genetic material, when she was actually on the borderline of considering donor gametes. Next slide. So when we really looked at literature and in terms of what it was telling us in RIF, that is recurrent implantation failures, what it said is, when you're doing RACGH, and this article was talking about RACGH and doing PGT, and doing a transfer with a euploid blastocyst for people who have RIF, the live birth rate reaches approximately up to 52%, with an implantation rates crossing 45%. Next slide. Now, there were a lot of other articles as well, which looked at what PGT and its impact in RIF and how it was helping them. Next slide. And there was also a pilot study which looked at RACGH and PGTA. And what they said is that you can actually improve the chances of implantation and clinical pregnancy in RIF by doing RACGH. And the chances were that you would get a clinical pregnancy rate of almost 70%. Next slide. So what we did was, having had some experience with the PGTA, we picked out and we did a study on the number of people who came in for PGTA for recurrent implantation failures. And now anybody who came with a recurrent implantation failures were given the option of either going for PGTA or going ahead for another cycle and a blastocyst transfer. Now, when we collected the data, we actually presented this in ESHRE, and this was accepted as a poster. These were our results. What we looked at is when somebody with RIF went in for PGTA, the live birth rates that we looked at were close to approximately 62%. And similarly, when we looked at the group that went without PGTA but went for transfers, their live birth rates was also close to 60%. But here, what you have to look at is PGTA, we achieved this pregnancy rate, or rather this live birth rate, with only a single transfer. But when we are looking at the group who achieved a live birth rate of 60%, they needed more than one, approximately 2 to 3 transfers to achieve that live birth rate. So what has PGT helped in this group of people? According to our experience, the time to pregnancy has been reduced for them. And also because we can go for a single embryo transfer, in these women, the chances of multiple pregnancy was also lower. So is there a role for RIF? Frankly, you have to pick and choose. You can still say that the live birth rates are similar whether you go for PGTA or not, but there are certain other advantages like time to pregnancy and lowering your multiple pregnancy. Next slide. Let's look at the other, indication for PGTA, recurrent pregnancy loss, and what its impact has been. Next slide. Now, this was a lady who was just 29 years old, PCO, hypothyroid, secondary infertility. She had 3 miscarriages. All of them miscarriages were in the first trimester. When she had the whole RPL profile assessment done, everything was entirely normal, including the karyotype. And the male just had the teratozoospermia and no other issues. DFI was at the borderline of 23, but because of the previous miscarriages and everything, we suggested TISA, which they agreed to. We went on to do IVF, and we got 6 blastocysts. Obviously, 29 PCO, we had a good number of blastocysts. But look at the numbers that we ended up, which were genetically normal. Out of 6, there were only 2 that were genetically normal. Next slide. So looking at that, we also did a bit of a review in terms of literature as to what was the effect of PGT on women with RPL. And this study has shown that by doing PGTA, there's a live birth of 53% and a miscarriage rate of 7%. If a woman went for PGTA and with a history of miscarriages. But in the same aspect, if they chose to go for expectant management, they had a similar live birth rate, or probably slightly better live birth rate of 67% as compared to 55% with PGTA. But look at the miscarriage. It was 24% with an expectant management as compared to 7% with PGTA. So next slide. So when we're actually looking at this scenario, we also did some more literature search, and this is what we have seen across, is that the clinical pregnancy rate or the live birth rate is similar whether you're looking at expectant or you're looking at PGTA. But where the difference comes is in terms of your miscarriage rate. Next slide. And we have quite a few studies which are actually telling us the same thing, is that the PGTA may not be a cost-effective strategy in women with recurrent miscarriages, but the benefit it provides you is that it decreases your risk of miscarriage. Next slide. Now, this was also a poster that we had presented to ESHRE a couple of years ago. And here what we did was we looked at the women that came to us with recurrent miscarriages. And these were people who had at least 2 or more miscarriages. And they were all younger than 35 because we didn't want to compound the issue having a woman above 35 as well. So we just picked out the women who were less than 35 and normal karyotyping, and everything, it was almost idiopathic recurrent pregnancy loss. And we looked at the aneuploidy rates. And what we found was that the aneuploidy rate, even in this group of women, was almost close to 80%. Then this should have been somewhere close to between 40 to 50% in a woman who's less than 35. It was actually double. But when they went for PGT and they went and had a transfer, the pregnancy rates were very good at 70%. So what we have established with our data is that women who have recurrent miscarriages actually have embryos which are more aneuploid than their counterparts who are also age matched. But the issue is that the implantations for them still remain good if we have got a normal embryo that has been transferred. Next slide. Now, in some of the indications, like I've showed you, there's also a role for severe male factor infertility and PGTA. So we looked at our data when we are talking about male factor infertility. Next. And this is what we actually looked at. So what we did is we stratified them into 3 different groups based on the age of the man, and we looked at the sperm counts, and 3, we looked at the origin of the sperm. So when we looked at the male age, we found that the aneuploidy rates were similar whether the man was less than 40 or whether he was older than 40. But look at the live birth rate. The live birth rate by using an embryo which was genetically competent, we achieved a live birth rate of 68 in a younger man. But in an older man, we had a live birth rate of only 25. So this was significant that even though the aneuploidy rates were similar, the live birth rates were drastically different. Now let's look at the second category based on the sperm analysis and the sperm counts. So somebody who had less than 5 million had a similar aneuploidy rate as a man who had counts of more than 5 million. And they also had the same kind of live birth rate, which is 50% and 60%, even if you did PGTA or not. So what about the origin of the sperm? Even in testicular sperm or ejaculate sperm, the rate of aneuploidy remained the same, and so did the live birth rate, 60 to 64%. Next slide. So our conclusion really was that when we are looking at male factor infertility, the aneuploidy rates remained the same whether it was an older man or a younger man, whether the counts were less than 5 or more than 5, or whether it was a testicular sperm or a ejaculated sperm. Where the difference came was in live birth rate, that as a man grows older, the chances of live birth was decreased. So here in male factor, the concept of PGT is still a bit blurred. Now, because like I said, we have a huge data of PGT, we did also some further studies on this, and we wanted to check what was the predictive capacity of an embryo morphology compared to the genetic competence. So what we looked at was out of 801 embryos which were biopsied, we found that they were only approximately 42% which were euploid and 57 were actually aneuploid. But when we looked at based on their grades, this is what we found. Was grade 1, we had 75% which were aneuploid, grade 2, 54%, and grade 3, 61%. So similar really in terms of their aneuploidy rates, which means that embryoploidy cannot be predicted either by the embryo quality or the grades that we see. Next slide. Now, just to summarize the results that we have had, what we found that when a woman crosses 37, we reach a pregnancy rate between, or rather live birth rate between 65 to 70%. If we are using PGT for recurrent implantation failure, we have a 63% live birth. If you have a woman with recurrent pregnancy loss, you have a 60% live birth and a reduction of miscarriage down to approximately 10 to 11%. Next slide. when and how or whom should we be advising PGT for? Well, if you have a young woman, less than 35, and she has good number of embryos, PGT is only going to help her in reducing her time to pregnancy. That's the first idea. The second thing is, if you have a woman who's crossed 37 and she has good number of embryos, PGT will help you improve her live birth. What if you have a woman who's above 37 but does not have good number of embryos, or rather has embryos which are around 2 or 3? Then the role of PGT is still debatable, because they could still go for a transfer with the embryos that they have created and possibly get the same kind of cumulative live birth rate. Next slide. What about recurrent implantation failure? Now, the role of PGT, at least when it came to our data, we found that it has reduced the time to pregnancy. How did it do that? Because you are able to achieve the same live birth in one transfer that you would have probably achieved by 2 or 3 transfers. So it has reduced the time to pregnancy and also increased live birth. What about the other category of recurrent pregnancy loss? Well, you probably have the same kind of pregnancy or live birth rate as expectant management, but the most important aspect and the impact of PGT in this group has been to reduce your miscarriages. Next slide. So just a few other points to tie up this whole concept of PGT. What we have seen is that when you have a patient with more than one embryo, IVF with PGTA reduces healthcare costs. It shortens the treatment time, or the time that it takes for a woman to conceive. It reduces the risk of failed embryo transfers and reduces clinical miscarriage as well. Next slide. Now, this has basically very clearly told us, and the green bars are for PGT and the orange bars are for people who did not have PGT. Obviously, when we are really looking at the implantation rates, they are better. Next slide. So when we really looked at, best trial, what it actually told us was that the delivery rates were similar. That is 70% after a euploid, single embryo transfer, versus 72% after untested 2 embryo transfer, which means that if you want to have, or rather, rule out multiple pregnancy, then the choice is to go for PGT and go for a transfer of single embryo. But it gives you the same kind of live birth rates when you're going for 2 untested embryos, provided the women are younger and they are good quality embryos. Next slide. So, even this concept about the cost differential, and because that is the most important thing we talk about when we're talking about PGT, is it really relevant for women to spend the amount of money that they do to do PGTA, and how is it actually helping? Because the concept is, your cumulative live birth rates are similar to what you would do when you're doing PGTA. So when they looked at the cost differentials, they found that once you have more than 2 embryos, then your cost is actually justifiable when you're doing PGTA, but not if it's anything less, or also not as much if your embryos are more than 7 to 8. Next slide. Now, this is a concept which I think has not been shaken over time, and that if at all there's any role for PGTA, it is in reducing your time to pregnancy. So it will take you more attempts and more longer to conceive, whereas if you do PGTA, it just takes you, it ends your journey much quicker. Next. But this is one aspect which we should never forget, is that with the advancing technology, PGT doesn't mean that it is for everybody. Why? Because it is associated with a lower chance of receiving a transfer. Why? Because right now we are looking at the fact that it has to be a blastocyst biopsy, a trophectoderm biopsy, for you to get to that point of doing PGT. Now, how many people will actually get to that point of having a blastocyst? So there could be some women who we are waiting for blastocyst and their embryos actually perish before they become blastocysts. So there's a lower chance of receiving a transfer. and less embryos obviously being available for transfer or for cryopreservation. So when we are counseling women, these concepts have to be brought to their notice. Next. So let's look at the goal of ART and where we are at this point in time. Does PGT give us a single child which is healthy? The answer is yes. Does it give us a good pregnancy rate? The answer is yes. Does it shorten the time to pregnancy? The answer is yes. Does it reduce complications? Answer is yes. Does it reduce the chance of birth defects? Again, the answer is yes. Does it reduce multiple pregnancy? The answer is yes. So where is it falling short? Next. So does PGT satisfy this? Yes. So where is the problem? The problem is here. The problem is this technology and this concept comes with a cost. So whenever we are choosing to consider PGT for anybody, we actually have to put all of this information together and see whether it actually makes sense for them. Thank you very much.
Thank you, Dr. Rao, for very clear-cut presentation along with interesting cases. So now we will go for the question and answer session. So questions are already started coming. So I would request audience to please share your questions in the chat mode. So we'll go for the questions. Just a minute. So this is a question about endometrioma. I think this is to Dr. Jatin. If we have operated combined endometrioma and adenomyosis lesion, how long we should wait before ART? 3 month agonist versus 1 month in such a case. What is your choice?
If you've done a lot of wedge resection of the adenomyosis, then I think 2 to 3 months wait for at least embryo transfer. Stimulation could be started after a month or so once she absolutely recovers. But transfer you would have to wait for at least 3 months, if you've done a lot of resection of adenomyosis.
Yeah. So this is from Dr.
As I told you, 3 months of suppression I am not in favor of. If there is too much of residual disease, still I think after a good pickup and embryo freezing, 1 depot usually suffices to get a good.
Yeah.
Can I ask a question to Dr. Durga?
Please.
Yes, please.
Excellent presentation. Thank you so much. A lot of concepts got cleared. Only thing is, I was wondering for those elderly men above the age of 40,
Yes.
would it be the live birth rates are lower because their female partners are also likely to be
Absolutely. That could be the the confounding factor, because when you're really looking at aneuploidy, there wasn't much of a change.
Yeah,
but that could entirely be true that the woman also could be much older.
Yeah. And the second thing was, I think, so when you say 60% pregnancy rate for all 3 categories, advanced age, recurrent miscarriages and recurrent implantation failures, that is if they reach an embryo transfer.
Absolutely.
Euploid. So these are pregnancy rates per transfer, not per started cases.
No.
So on an average, how many patients have all aneuploidic and don't have transfer? Say about 37.
No, I would put it like this. The number of patients that we do not end up going for a transfer at all.
Yeah.
And it could be 2 groups really. One could be the fact that they didn't reach blastocyst stage at all.
Okay.
And the second group is the one in which blastocysts were there, but they were aneuploid. If I put them together, then I would say, at least approximately 15 to 20% of the patients will not go for a transfer.
Oh, that's a low percentage.
Yeah.
I thought it will be around 40-50.
No, but
37.
Yes.
Good. That's good. Thank you.
This is another question on endometriosis. Are there any chance of growth of endometrioma with our stimulation? This is from Dr. Vidya.
Sorry?
Is there any chance of growth of endometrioma with our stimulation?
No. I showed 2 or 3 slides on that, and I also showed there are about 6 studies which have clearly shown there is no effect on recurrence rates Even if you do 2 or 3 stimulation cycles or repeated IVFs or aggressive IVFs, the recurrence is not increased with ovarian stimulation. So that there's enough evidence on that. So we need to relax, and therefore they say that immediate ART backup after good endoscopic surgery is indicated, and there's no need to fear that she will have a recurrence.
Okay. So I just wanted to tell both of you that there are a lot of appreciation messages coming. Excellent, sir. Very nice presentation, madam. So it's there. So I'm not going to that. I'm going to the question. What is the strategies to improve implantation in endometriosis, and especially any add-ons that you would suggest?
No, so the best thing which I would again repeat is to do a frozen transfer and not do a fresh transfer. In the fresh cycle, the stimulation cycle, don't bother about down regulation. You don't need to do that. You can use an antagonist or an agonist, whichever is your choice. Give the right dose, because a lot of them have a diminished ovarian reserve. So maybe 300 to start with. Whether if you're a fan of HMG, you could start with HMG or use REC-FSH, REC-LH combination, that's left to you. But that good stimulation to get the perfect embryos, especially after a good surgery, is very important. For transfer, I recommend down regulation, because we have a lot of studies where they show that down regulated FET is the best in endometriosis specifically. So you get much higher takeover rates with down regulated FET. But now again, there is some concept of higher incidence of PIH with the use of artificial hormone replacement for FETs and all. So we are again rethinking about whether natural cycle FET would be the way to go. In endometriosis, I think a little bit of down regulation would be required on this.
Okay. So there is one specific question. What is the dose of depot? Can you please tell us?
3.75.
Dose 3.75. Yeah.
Just one depot. I don't use the 11 because it's too strong, and 3 months we don't need. There's too much of menopausal symptoms, backaches, leg pain. It's not required.
Yeah.
I showed you the Cochrane analysis, which also shows that this agonist pre-treatment doesn't improve live birth rates at all in IVF. So it is absolutely not justified as of evidence available today.
Okay, yeah. So but I think there is a perception that agonist.
That's why I put that slide.
There is a perception.
Everybody is giving 3 depots.
Yes.
Patient,
Even in our
already her AMH is low, then she's over suppressed. The menstruation doesn't come back after 3 months, so she panics. Plus all the pain, and there's no justification for that.
Yeah, thank you. So this is a question to Dr. Rao. How effective is polar body biopsy for aneuploidy detection? Can we be less invasive? This is again from Dr. Sushma Bixi.
Very true. The concept of polar biopsy obviously is, a bit intriguing, because that way you are not causing any kind of breach on the trophectoderm, and you're not removing cells, so you're not reducing your implantation rates. It's a good concept, but the only problem with the polar body biopsy is the fact that you're only going to be checking the genetic competence of the oocyte, and you will not know about the whole embryo. So that's the limitation of doing a polar body biopsy. They did look at about, doing it after fertilization of the 2 polar bodies, post-fertilization as well. But it hasn't given us the same kind of concordance as much as trophectoderm does. Even now, as I said, even in mosaicism, even when we are taking a few cells from the trophectoderm, we are not very sure that it is a representation of the whole embryo. Even now, we are still saying that mosaic embryo may have intact, inner cell mass. So there are still a lot of concepts and a lot of things that we are not very clear of. But, that's the best that we can do with the technology that we have now.
Okay. Thank you.
So Dr. Durga, since we say that, with PGT, we reduce the time to live birth and we eliminate miscarriages. And on the other hand, like you showed in your last very nice slide, a lot of money involved and costs involved and all. As a take-home message, which patient would you say it is mandatory where you are really convinced that PGT is the way to go of all these categories?
Frankly, there isn't any category that I would say PGT is the only answer for you. There is nobody. Because when you're looking at older women, you may not get as many embryos as they would need to get to a euploid embryo. And when you're really looking at, they go for multiple cycles, we have to wait for, blastocysts, and we have to check those blastocysts for aneuploidy. They spend so much money by the time they get to the point of PGT. Rather than that, they might as well go for, multiple transfers of the embryos that they've created, because the cumulative live birth rate still remains the same. So it is only, if at all you ask me, if you, put a gun to my head and say, give me one indication, the only thing I would say is that time to pregnancy, Dr. Shah. If they say that, this is it, I need to get the best chance that you can give me in this time that I have. I'm either flying off somewhere or I need to...
the emotional turmoil of a miscarriage.
Yes.
So if money is not an issue, then these two are good indications.
Correct. That's time to pregnancy, I think, is the only indication that it seems to work for.
Right. Thank you.
Yeah, thank you. So now the question is like, can you please tell approximate cost of PGS? There's a lot of money, so everybody wants to know how much.
So let me put it this way. Each embryo biopsy analysis and everything can take you back anywhere from approximately 20,000 to 40,000. I'm talking about each embryo.
Or embryo.
Yeah.
That's the figures that we are actually looking at.
Okay.
And this does not involve the amount of money that they spend on the IVF cycle and the whole process.
This is add-on.
Yeah.
So there is one, give us some inspiration, madam. This is a remark and regarding future in reproductive medicine.
I think, frankly, I feel very privileged to be in the fertility space for now, because the direction that medicine is taking now, it is looking towards preventive. Let it be cancer, let it be anything. We are really looking at preventive medicine. To me, what could be more preventive than the fact that you are able to genetically engineer an embryo and bring about a healthy child? To me, I think that is the peak of what mankind and what health can give. And what better than a fertility specialist, obviously, to start the journey. So I think, as a fertility specialist, I think we are in the best space possible. I think this is the best decades to be in fertility specialist, because the kind of work that is going on in stem cells, the kind of work that we are able to do in this space, I think is what is going to revolutionize the kind of health and mankind is going to have in the future. So, what more inspiration can you need?
Yes, there is
Thank you.
Well said.
Yes.
there's an egg which is not
There is one more question on protocol. Can agonist protocol be done for severe endometriosis with normal reserve less than 35 years of age?
Yes, of course you can. There's I said choice between agonist and antagonist is totally left to you. If you have that rare patient of endometriosis who also has a high AMH and she is a potential high responder, then I would not recommend the agonist protocol, because you don't have the option of the agonist trigger and doing a freeze-all then. And you're forced to give an HCG trigger. So, but anybody with an AMH of say less than 2.5, 2.7 and endometriosis, however severe it is, you can use the agonist protocol. It's your choice whether you want, because my personal favorite is the agonist, because you get a perfectly synchronous cohort of follicles. You get all the same size. In antagonist, very often, in 30% of patients, one follicle is bigger and the others are smaller, and you sometimes end up with an asynchronous cohort. So in a normal AMH, it may not matter much. But especially poor responders, I prefer the agonist, contrary to what everyone else does. And except high responders, my choice is agonist for most patients.
Yeah. Thank you for clarifying. So overall, there are a lot of messages coming, very informative for both of you, and then excellent presentation. So there is one very basic thing is what's the difference between fresh and frozen transfer? How, when do you decide? Could you please explain on that?
No, as a general rule, I think you could, opt for frozen transfer for most cases of endometriosis for all the reasons I gave earlier, because the endometrium is not very good because of all those 6 factors which I showed in a fresh cycle, because the luteal phase is affected by the endometriosis and the receptivity is altered. So best is to do a stimulation, freeze-all, and then do a frozen transfer with a good agonist down regulation. That is ideal. Now, if you don't have a very good vitrification backup setup, or you're not very sure of your freeze-all results, then for patients who have a normal progesterone between 0.5 and 1.5 on the day of HCG, they have less than 13 oocytes, and the endometrium is looking good, maybe you could do a fresh transfer in some of those patients and expect a reasonable pregnancy rate. But a lot of studies now, which I showed in the presentation, that freeze-all and frozen almost doubles the pregnancy rate. So there wouldn't be much justification in doing a fresh transfer for endometriosis patients.
Yes, even I have seen a recent presentation in X-ray. The frozen is appears to be better pregnancy rate. Last presentation I have seen. So, in the contrary to usual belief, going for fresh.
21 days tablets. Yes.
There is one case question on for patient with endometrioma of 4 centimeter and its tube is blocked. Can we try OI without surgery for 3 cycles?
Try OI.
Ovulation induction without surgery.
That is,
for
if the tubal block is say a proximal block, means you don't have hydrosalpinx. The tube block is on the same side as the endometrioma, then it's fine. And the contralateral side is absolutely normal. Tube ovarian relationship, everything is fine. Patient is very young, she has a very good ovarian reserve. Then you can definitely try 3 months of maybe ovarian stimulation with IUI or whatever you normally do, and then think of IVF. But anything out of the way, if she's a hydrosalpinx, then she needs an operative intervention or a clipping anyway. Or, if it's on contralateral sides, the tubal block is on the other side and the endometrioma is on the other side, then obviously you need to go for IVF at the earliest.
Okay, thank you. There is one question. Kindly let us know which books are the best to study about reproductive medicine.
Attend all the webinars.
Yeah.
You can currently do 10 webinars.
I completely agree. I don't think anybody would give you the compilation of the kind of studies that Dr. Jatin has done. So, what best is this? I think you get the most comprehensive view of everything.
Yeah, well researched.
Yeah.
It is good.
Thank you.
But Gardner's book is good on a serious.
Gardner, yeah.
Yeah, Gardner's handbook of IVF is good. And then you have clinical and laboratory books by, I think, Colin Howells and Ziv Shoham and all of them, which are considered Bible. So there are 2 volumes, one on clinical and laboratory. That's good to read. But finally, then you have to start doing it, get a visiting embryologist, get somebody to do pickups, start learning hands-on, webinars, conferences. Way to go.
So the next question is, to Dr. Rao, what is rate of mosaic embryos in your experience? Do you transfer them if there is no euploidy embryos after counseling? What was the outcome, in case you have done it?
Right. So thankfully till now we haven't transferred any mosaic embryos, but we don't discard them either. Now this is where I think when we had the consensus from the PGDC committee meeting, they have given us clear guidelines on what our choices of the embryos should they be mosaic. So which embryo are you likely to transfer? Now, any embryo which has mosaicism of less than 20 to 30%, you are able to consider. But it depends on which embryo, which chromosome it shows mosaicism in. If you have multiple embryos, obviously the recommendation is not to transfer. So there are clear recommendations given on them based on the chromosomes that are mosaic. So there's a little help there that is already available.
Thank you. This is again on frozen embryo transfer. In frozen embryo transfer cycle, we give estrogen for at least 3 months. Is it okay with endometriosis?
Why would you give estrogen?
I do not know, but I think there is a practice people are doing, some of the doctors are doing. It's not required, no?
No.
Unless until...
In fact, giving prolonged estradiol valeriate, if you do transfer beyond 30 days of estrogen administration, your pregnancy rates are not good and early pregnancy loss is very high. So although I told you can go to day 20, 25, but maximum is day 25, then you should start progesterone and do transfer by day 30, 31. Maximum, if you want to push. So IUL is usually day 18, day 20. But if at all endometrium is thin and you want to keep giving estradiol, that's fine. But more than 30 days is detrimental to the outcome. So it's not more than 30 days before embryo transfer, before you start progesterone.
Yeah. So, Dr. Jatin, is there minimum number of days of progynesia in FET cycles in normal responders?
Yeah.
So minimum 12 days.
10 to 14 days is ideal, but it depends on the endometrium. So there's no fixed number of days. You have to be happy with the endometrium, the appearance, the thickness, the blood flow, and then decide when to do transfer.
Yeah. Okay. I think we are almost through, except very complimentary message to both of you. And there are questions about His Oasis offers fellowship courses and fee structure. So for that, Madam, if you want to.
There's actually a lot of information on our website. Yes, we do offer fellowship. So that information is available on our website. I wouldn't want to use this platform.
Yeah. Okay. Yeah. Okay.
Thank you.
Okay.
Okay. So I think we are almost last. Just checking and refreshing if there is anything, chat questions. Yeah. There is one thing on clipping only in ultrasound proved hydrosulfings. It should be frozen pelvis also before FET.
No, clipping is ideal. Na? Even if you have frozen transfer, most endoscopic surgeons are able to find their way to the corner. Very rarely they can't. But if you can't do nowadays anyway, we recommend clipping over salpingectomy. So it's mandatory. If you have ultrasound detected communicating hydrosalpinx, you should clip it. Otherwise, your pregnancy rates will be only 5% instead of 50%. So that's a well-known for more than 2 decades.
Yeah. So there is one specific question, Dr. Jatin. Please comment on success rate of egg freezing in your experience.
See, it's an excellent question. But the problem is all over the world. The statistics are that of all the eggs which have been frozen, only 4% have been used. So only 4% of the girls who have frozen their eggs anywhere in the world have actually come back to use them. And I think that's the experience with all Indian clinics as well, because we started in a big way, say about 5 years ago. And only in the last 2 years, it's that, we have 3 to 5 per month. Otherwise, it used to be 5 in a year. So now I don't know when all these girls will come back to use them. But we've done a lot of frozen eggs for egg donation cycles. And there the success rates are almost the same as fresh eggs. So we are quite confident that it will be the same and there should not be much of a problem.
Yeah. Okay.
It all depends on at what age they froze it at and what was the endocrine profile and the age profile when they did the initial freezing. If somebody is frozen at 40, she can't expect more than a 10% live birth rate. And somebody is frozen at 30, she can expect 60%. So that's a huge difference.
Okay. So I think we are good and on the interest of time. And if there are any further comment or anything that message you want to give, otherwise we would conclude the meeting. Yeah. Okay. So So thank you both of you for joining us and giving us a very clear-cut guidance on what should be done and how to select the patient in case of both the endometriosis and IVF, and also PGS specifically with the interesting cases. And of course, the guideline that you have already shared us will be very useful for the audience. And so on behalf of MSD, I would like to thank both of you and also the audience for their participation and through putting a lot of questions. And so with that note, thank you. And
thank you, Dr. Super. Thank you, Durga.
Thank you, madam.
Thank you, sir.
Thank you.
Thank you, madam.
Thank you, Vishal. Thank you.
Thank you, sir. I think we had a wonderful audience.